Welcome back to the deep dive. Today, we're plunging into, well, one of orthopedic surgery's really quite formidable challenges,
Mhm.
the irreparable rotator cuff tear.
hmm
This isn't your average tear, is it? It's a complex problem that really pushes the boundaries of surgical ingenuity and, of course, patient care.
That's absolutely right, yes. When we talk about an irreparable tear, we're using a specific clinical definition. It's based on factors that go beyond just the size of the tear itself, although, size is often part of it.
Right.
The literature really points to some key characteristics that make a torn rotator cuff truly irreparable.
Okay, let's unpack that then. What exactly distinguishes an irreparable tear from, say, just a massive tear that, might still be potentially repairable?
That's a very good question. Whilst many irreparable tears are massive,
Yeah.
involving more than one or two tendons, the term irreparable specifically refers to factors that make a successful, durable surgical repair.
Right.
Well, unlikely, or even impossible. The main culprits here are, firstly, the degree of retraction. That's how far the torn tendon has pulled back from its attachment point.
Mhm.
Often it's so severe you simply cannot physically mobilize the tissue back to the bone without putting it under excessive tension.
Too tight?
Exactly.
Yeah.
And perhaps even more critically, it's about the quality of the muscle tissue itself.
Muscle quality. How does that play a role?
We're talking about muscle impairment,
Yeah.
specifically muscle atrophy, where the muscle bulk actually shrinks, and fatty infiltration. That's where fat cells start replacing healthy muscle fibers.
Right.
This change in the tissue composition means the muscle is just less functional. And even if you could somehow reattach the tendon, the muscle unit itself wouldn't generate enough force. Plus, that compromised tissue is much less likely to heal properly to the bone.
So it's not just the size of the hole or how far it's pulled back, but what's actually happened to the muscle that's connected to that tendon.
Precisely, yes. Think of it like trying to sew, frayed, brittle fabric back together. It's just not going to hold the tension well, is it? The sources you've gathered really highlight this. For posterior superior tears, those involving the supraspinatus and maybe the infraspinatus tendons, the Gerber criteria, are often mentioned. They describe a scenario where even if you tried to mobilize the torn tendon, you physically cannot get it close enough to the bone insertion site to fix it without undue tension when the arm is brought down to, say, 60 degrees of abduction or less. That tells you straight away the tendon is severely retracted and probably quite fibrotic, quite stiff.
That paints a really vivid picture, actually, of how contracted and, well, immobile the tissue can become.
Right.
And are there specific clinical signs, then, things you look for that point towards this rather grim prognosis?
Yes, absolutely. There's several sort of red flags that surgeons look for, both from the clinical examination and from imaging, like X-rays and MRI scans. A long duration of symptoms is quite common, often 6 months or even longer. Significant weakness is another key sign, particularly weakness in external rotation. That's the ability to rotate your arm away from your body.
Right, turning outwards.
Yes, because that function is heavily reliant on those specific muscles, the supraspinatus and infraspinatus, which are often the ones torn.
And what about on the scans? What shows up there?
Well, on standard X-rays, a really key sign is a reduced acromiohumeral distance. That's the space between the top of the humerus, the ball part of the joint, and the underside of the acromion bone above it.
Okay.
If that space is less than about 6 millimeters, it's a strong indicator that the humeral head has started to migrate upwards because the torn cuff is no longer doing its job of holding it centered in the joint socket.
So the ball is riding high.
Exactly. Then MRI is crucial. It helps assess the tear itself, the size and retraction, but also the muscle quality we talked about. The PAT staging system describes the degree of tendon retraction. Stage 3, for instance, means the tendon is pulled all the way back to the rim of the socket, the glenoid rim. It's essentially completely off the humeral head.
Wow, stage 3 is totally disconnected then.
Pretty much, yes. And then the MRI also clearly shows the fatty infiltration within the muscle. We use the Gutalia classification to grade that. And studies consistently show that fatty infiltration exceeding 50%, so that Gutalia grade 3 or 4, is a very strong predictor that any attempt at a direct repair is, well, likely doomed to fail. The healing potential and muscle function are just too poor.
Okay, that gives us a really clear definition of what we're up against here. It's not just a big hole, is it? It's retracted, poor quality tissue, and often a shoulder joint that's already started to shift upward structurally.
Precisely.
So, our mission for this deep dive then is to take the material you've provided and really explore the whole landscape of solutions for these very challenging cases.
Exactly. And the literature offers a surprisingly wide spectrum of treatment strategies.
Mm.
It ranges from non-surgical approaches right through to highly complex surgical reconstructions and even joint replacement surgery. So we'll delve into each one, try to understand the rationale behind it, look at the evidence supporting it, and crucially, figure out who might be the right candidate for which particular procedure.
Fantastic. Let's really dive into understanding why these are so difficult to treat surgically first. You mentioned direct repair isn't usually an option. Why is that, beyond the factors we've just, covered?
Well, even for massive tears that maybe don't quite meet the strict definition of irreparable but are still very large, the mechanical environment and the biological healing potential are already quite compromised.
Right.
The re-tear rates after surgery for these massive repairs are frankly notoriously high in the literature. They're often cited somewhere between 40% and in some studies up to 91%.
91%. Wow.
Yes, it's a sobering figure. It means that even if a surgeon can technically manage to pull the tissues together and stitch them down, the chances of that repair breaking down again over time are really quite significant. Now, for truly irreparable tears, with that severe retraction and poor muscle quality we talked about, the chance of a successful functional repair drops even lower, potentially right up towards that higher end of the range. Attempting a direct repair in that scenario can sometimes even make things worse, more pain, limited motion, or it just fails very quickly.
That 91% figure is really stark, isn't it? It certainly underscores the need for alternative approaches, and it also highlights something the sources point out, that the goal isn't always achieving anatomical perfection.
Absolutely not. For many patients with irreparable tears, particularly perhaps older individuals or those who don't need to perform strenuous overhead activities, the primary goals of treatment tend to shift.
Okay.
We're often focused much more on improving pain, restoring enough function for everyday activities, activities of daily living, and just generally enhancing their overall quality of life. It becomes less about restoring the shoulder to how it was before the injury or achieving some anatomical ideal, and more about making it a comfortable and usable limb again.
So managing expectations is absolutely key here. Given those challenges with direct repair, what's typically the first avenue that's explored?
Well, as with many orthopedic conditions, really, the initial management is often conservative, non-operative, particularly for patients who aren't aiming for high-level athletic performance or perhaps those who have significant other health issues, comorbidities.
Right.
The literature actually shows that even quite substantial tears, including some classified as massive, can sometimes be managed non-operatively with quite satisfactory results, at least for a significant period.
And what does that non-operative approach look like in practice?
It's usually a multi-pronged strategy. Physiotherapy is absolutely the cornerstone, a structured rehabilitation program tailored specifically to the patient's needs.
Okay.
This focuses on strengthening the remaining intact rotator cuff muscles, improving the function of compensatory muscles like the deltoid and the scapular stabilizers around the shoulder blade, trying to regain a range of motion, and also correcting posture that might be contributing to impingement problems.
So essentially training the body to work around the problem.
Exactly that, yes. Alongside the therapy, medical management is important too. This includes things like oral pain relief and anti-inflammatory medications just to manage the symptoms day to day. Injections into the subacromial space are also frequently used. Most commonly, that's corticosteroids to reduce inflammation and hopefully pain. Some sources also mention using hyaluronic acid or perhaps platelet-rich plasma, PRP, although I'd say the evidence for their long-term benefit, specifically in irreparable tears, is still evolving.
Right. And does this conservative approach, does it genuinely make a difference? You mentioned satisfactory results earlier.
Oh, absolutely can, yes.
Yeah.
There are studies providing good evidence for this. For instance, Ainsworth and colleagues reported significant improvements in patient-reported outcome scores, things like the Oxford Shoulder Score and the SF-36 Quality of Life Score, after just a 12-week multimodal physiotherapy program in patients who had massive tears.
That's quite notable progress just from dedicated physio, isn't it?
It is, yes. And then there's the really striking Levy study. They looked specifically at patients with irreparable rotator cuff tears who also had pseudoparalysis. That's the inability to actively lift the arm above about 90 degrees.
Okay.
They implemented a very targeted training program focusing on the anterior deltoid muscle, the muscle at the front of the shoulder. And the results were quite dramatic. Their mean constant scores, which measure function, went from a severely disabled level of about 26 up to 63, which represents a much more functional level.
Wow.
And perhaps even more impressively, their average active forward flexion, lifting the arm forwards, improved from a mere 40 degrees to an average of 160 degrees.
So going from barely being able to lift your arm to nearly full elevation just by training the deltoid muscle, that's a really powerful demonstration of compensation, isn't it?
It truly is. It really highlights the importance of assessing and then optimizing the function of the deltoid and the other muscles surrounding the shoulder joint when the rotator cuff itself is deficient. It shows that even if the underlying structural tear doesn't actually change, the functional capacity can be significantly improved through dedicated rehabilitation. As some studies, like one by Zheng et al., observed, some patients can maintain pretty satisfactory function non-operatively for years, even whilst the pathology, the tear itself, might be progressing structurally on scans.
Okay, so conservative management, especially that focused rehab, is a really critical first step and can yield some impressive functional gains. But what happens if conservative treatment just isn't sufficient, particularly for persistent pain?
Yes, when pain remains a significant issue despite those conservative efforts, the next step often involves arthroscopic procedures, keyhole surgery.
Right.
These are typically less extensive than open surgery and, importantly, they're primarily aimed at providing pain relief rather than restoring the anatomical integrity of the torn cuff.
So treating the symptoms more directly then?
Precisely. The pain in many of these massive and irreparable tears is significantly driven by inflammation within the subacromial bursa. That's the fluid-filled sac that normally cushions the rotator cuff tendons underneath the acromion bone.
Okay.
This bursa can become really thickened and inflamed, and it contains pro-inflammatory cytokines, chemicals that cause pain. Also, the ragged edges of the torn tendons themselves can be a source of pain and mechanical irritation as the shoulder moves.
So what does the arthroscopic procedure actually involve doing?
Well, the core procedure is usually a thorough bursectomy. That means removing the inflamed subacromial buria arthroscopically. This is often combined with debridement, which essentially means trimming or smoothing out the ragged edges of the torn tendon ends. This can help alleviate that mechanical irritation and remove the inflamed tissue, thereby reducing pain.
And does this approach have good evidence behind it for pain relief?
Yes, studies do support its effectiveness, particularly in, say, older or less active patients. The Liam study, for example, showed significant improvements in AC scores, that's the American Shoulder and Elbow Surgeon score, and also a substantial reduction in pain scores following arthroscopic debridement and bursectomy.
So patients felt better.
Yes, they reported much less pain, often dropping several points on a standard visual analog scale for pain. The goal here really is to provide that pain relief whilst preserving any remaining functional muscle tissue, like perhaps parts of the posterior cuff or, crucially, the deltoid muscle, which is so important for overall shoulder function when the cuff is deficient.
That makes a lot of sense, a less invasive way to directly address a major source of the pain. But you mentioned earlier that this alone doesn't slow down the progression of osteoarthritis.
That's a really key limitation, yes, and something the sources are quite clear about. Whilst debridement definitely helps with pain by managing the inflamed bursa and the torn edges, it doesn't alter the fundamental biomechanics of the shoulder joint. It doesn't stop that potential superior humeral head migration and the increased joint wear that can happen over time.
So it treats a symptom.
Exactly.
Right.
It addresses a symptom, but not necessarily the underlying mechanical issue that might be driving future arthritis development. Now, alongside debridement, other procedures are often performed arthroscopically at the same time as adjuncts.
What kind of adjuncts are we talking about?
A very common one is addressing the long head of the biceps tendon. This might involve a tenotomy, which is cutting the tendon, or a tenodesis, which is cutting and then reattaching it elsewhere.
Okay.
The long head of the biceps tendon runs right through the shoulder joint, and it often becomes degenerative, frayed, or even partially torn in the setting of massive rotator cuff tears. And this itself can be a significant source of anterior shoulder pain at the front.
So it's another source of damaged tissue causing pain within the joint.
Exactly. Surgeons notice clinically that some patients who experienced a spontaneous rupture of their biceps tendon actually reported a paradoxical improvement in their overall shoulder pain.
Interesting.
Which led to the idea of intentionally performing a surgical tenotomy, cutting the biceps tendon arthroscopically. The usual technique is to cut the tendon near its origin on the glenoid, the socket, allowing it to retract down the arm out of the joint.
And the idea is just to remove that painful, degenerated bit of tissue from within the joint space.
Precisely. Cutting it near the origin is thought to reduce the risk of the remaining stump causing irritation later on. However, it's important to note that whilst tenotomy can provide good pain relief for specific biceps pathology, the literature actually presents somewhat conflicting long-term results when you compare it to debridement alone, specifically for the irreparable rotator cuff tear itself.
Right.
Some studies show no significant additional long-term functional benefit from just adding a tenotomy if the primary pathology isn't actually biceps-driven pain.
Interesting. So it's really an adjunct for a specific identifiable problem, not necessarily a universal benefit for all irreparable tears. What else might be done?
Suprascapular nerve release is another consideration sometimes. The SSN, the suprascapular nerve, innervates both the supraspinatus and infraspinatus muscles, the ones commonly affected in these posterosuperior irreparable tears.
Okay.
And the nerve itself can sometimes be a source of pain and weakness in these patients.
Why would the nerve get involved in a rotator cuff tear? That seems indirect.
Well, the exact mechanisms are still debated, actually. But the proposed ideas, the pathogenesis, include things like traction injury on the nerve as the torn muscles retract and pull on the nerve branches, or potentially entrapment of the nerve as it passes through specific anatomical notches near the shoulder blade, perhaps due to scar tissue formation or even the fatty infiltration that develops around the damaged muscle.
And how would that be diagnosed?
Clinical suspicion might arise from specific pain patterns or perhaps isolated muscle weakness that seems out of proportion. MRI can sometimes show severe atrophy of the supraspinatus and infraspinatus muscles or sometimes suggest areas of potential compression along the nerve's path. However, the gold standard really for confirming nerve involvement is electromyography, EMG, and nerve conduction studies. These directly assess the electrical activity and function of the nerve and the muscles it supplies.
And the treatment for that.
Conservative management is always the first line, things like rest, physiotherapy, anti-inflammatory medications. If there's clear evidence of nerve compression from the imaging or the EMG studies, or if the pain and weakness are really refractory to conservative care, then surgical decompression or release of the nerve can be performed, and that's often done arthroscopically nowadays as well.
We also touched briefly on tuberoplasty earlier, sometimes called reversed subacromial decompression. That sounds like it addresses the bone changes, the high-riding head you mentioned.
It does, yes. As the humeral head migrates superiorly, because there's no functioning rotator cuff holding it down, the greater tuberosity, that's the bony bump at the top of the humerus, where the cuff normally attaches, can start to rub directly against the underside of the acromion bone.
Ouch.
Yes, and this could be a significant source of pain and impingement, particularly during movement. Tuberoplasty, whether it's performed open as described originally by Fenlon or arthroscopically as described by Scheibel, involves surgically removing that prominent impinging portion of the greater tuberosity.
So you're essentially smoothing out the bones that are clashing together.
Exactly that. The goal isn't necessarily to create more space in the traditional subacromial decompression sense, but rather to create a smoother, less painful articulation between the humeral head and the acromion as the arm moves through its range. It's important, though, to preserve the coracoacromial arch during this procedure, as that structure provides important stability to the shoulder.
And does this help patients? What are the outcomes?
Studies specifically on tuberoplasty have reported improvements in pain levels, activities of daily living, range of motion, and also constant scores. What's particularly interesting, as noted by authors like Senlin and Scheibel, is that despite the fact that underlying osteoarthritis might continue to progress radiographically over time,
Right.
the clinical benefits derive from the tuberoplasty itself, so the pain reduction and the improved function that comes from alleviating that specific bony impingement can often still be maintained long-term.
Okay, that covers quite a range of arthroscopic interventions, mostly focused on pain and smoothing out the mechanics, it seems. Let's move on to something quite different now, a relatively newer concept that's mentioned in the sources, the subacromial biodegradable spacer. This device has certainly generated a lot of discussion, hasn't it?
It has indeed, yes.
Yeah.
And it's a fascinating area where the evidence is still actively evolving. The device, often known commercially as the in-space balloon, is typically made of polyallactide, which is a material that biodegrades slowly over time. It's inserted arthroscopically into that subacromial space, positioned above any remaining rotator cuff tissue and below the acromion bone, and then it's inflated, usually with saline solution.
So you're literally placing a balloon in the shoulder. What's the thinking behind doing that?
Well, the proposed mechanism is primarily biomechanical. The idea is that by occupying space in that subacromial area, it's hypothesized to, firstly, reduce friction between the humeral head and the acromion. Secondly, to help lower the humeral head slightly, pushing it back down towards a more centered position in the joint. And thirdly, to facilitate smoother gliding during arm movement.
And how is it actually used in practice?
Typically, it's implanted after the initial arthroscopic steps we've discussed, like a bracectomy and maybe some debridement. The surgeon selects the appropriate size of the spacer based on the size of the irreparable tear.
And how long does this balloon actually stay there?
Well, the material is designed to gradually deflate over about 10 weeks or so, and then fully degrade and be absorbed by the body over approximately 15 months. What was initially quite curious in the early literature was that clinical improvements reported by patients seemed to persist well beyond the point where the spacer had physically disintegrated.
That sounds quite promising, doesn't it? A temporary intervention with potentially lasting benefits. The initial theoretical benefits certainly sounded compelling, things like preserving the acromiohumeral distance, optimizing force balance.
That was certainly the initial hope, yes, and the theoretical basis for its use. The idea was that by temporarily lowering the humeral head and reducing that friction, it would improve pain and potentially even slow down the progression of degenerative changes in the joint.
But your source material includes some significant contrasting evidence about those theoretical benefits. This is where the deep dive really gets into the nuances of the research, I suppose.
Absolutely, and this is a really critical point for understanding the current landscape regarding these spacers. The Garrigues-Perez et al. Study, which was published in the Journal of the American Academy of Orthopedic Surgeons back in 2022,
Right.
presented findings that directly challenged some of those initial theoretical benefits.
Right.
Their results, quite significantly, did not demonstrate that the spacer prevented superior humeral head migration or indeed arthropathic changes, the development of arthritis.
So not only did it not prevent them, but the study actually found that the acromiohumeral distance, that space we talked about, actually worsened over time.
Yeah.
And the Hamada stage, which is the X-ray grading of the arthritis, also worsened during their follow-up period.
That is correct. That was a key and somewhat surprising finding because it directly contradicted that core biomechanical goal of the device, which was to maintain or improve the subacromial space and prevent that upward migration. Furthermore, their study reported relatively low functional outcomes. When they looked at various standard orthopedic scores like the Constant score, the ACEs, the Simple Shoulder Test, SST, and the DSH score, the results were generally not as robust as perhaps seen with other procedures or maybe in some of the initial early reports on the spacer. Patient satisfaction in their series was also only around 62.5%.
So objectively, the joint seemed to be getting worse on X-rays, and the functional benefits and patient happiness weren't overwhelmingly positive in that study.
That's a fair summary of their specific findings, yes. Whilst perceived quality of life, measured by something like the Euro-QOL score, might have seemed less impaired, the objective measures of the joint structure itself and the specific shoulder function scores were, well, concerningly low, or even worsening over time in their cohort.
And what about complications? Did that study shed any light on the risks involved?
Yes, it did. Garrigues-Perez and colleagues reported a 13% complication rate in their series. This included instances of deep infection and also balloon migration, where the spacer moves from its intended position.
Okay. Now, whilst these aren't necessarily exceedingly high rates compared to some very complex joint procedures, they are nevertheless serious complications that can require further surgery and potentially jeopardize the overall viability of the shoulder joint, perhaps in a situation where a less complex intervention pathway might otherwise have been chosen.
Okay, so the subacromial spacer.
Hmm.
It's clearly an innovative concept, but the evidence, certainly based on this more recent study, appears quite mixed. While it might offer some temporary pain relief or functional improvement for certain patients, this higher-level evidence raises significant questions about its ability to durably prevent that superior migration or the progression of arthritis. And it highlights potentially lower functional outcomes and a non-trivial risk of complications compared to what might have been initially hoped or reported. That's a really critical piece of evolving understanding based on the literature, isn't it? It certainly is. And it makes the decision of whether or not to use a spacer much more complex now. It requires really careful consideration of this conflicting data alongside all the other treatment options that are available.
Absolutely. Moving on from temporary implants then, let's look at attempts to actually modify the torn tissue itself. The sources discuss the possibility of doing a partial rotator cuff repair. How is that different from attempting a full repair, which we know is often not possible?
Right. So in an irreparable tear, by definition, you cannot pull all the torn tendon back to its original anatomical footprint on the bone without creating excessive tension. A partial repair is based on a biomechanical concept often called the suspension bridge analogy, which was popularized by Dr. Stephen Burkhart.
Okay.
The idea is that certain key components of the rotator cuff, particularly a thickened band within it called the rotator cable, act a bit like the main cables of a suspension bridge. They transmit forces across the joint, even if parts of the deck, the rest of the tendon, are missing.
So if you can't fix everything, the idea is to fix the most structurally important parts to restore at least some function.
Precisely. The goal isn't full anatomical coverage of the bone, but rather to repair enough tissue to restore a stable fulcrum for the humeral head to rotate against, and crucially, to reestablish some of the important transverse force couples that help keep the humeral head centered in the glenoid socket during movement.
Right.
The literature suggests that for posterosuperior tears, repairing at least the whole subscapularis tendon at the front, if that's involved, and at least the inferior half of the infraspinatus tendon at the back, particularly where it connects to that rotator cable structure, seems to be critical for achieving a functionally successful partial repair.
And does this approach, this functional partial repair, actually work in practice?
Well, studies have shown some promising results. For example, Porcellani and colleagues published on the outcomes of doing a functional partial repair of just the infraspinatus in massive tears, even leaving parts of the greater tuberosity footprint uncovered. They reported significant improvements in constant scores and simple shoulder test scores, indicating better function and reduced pain. And crucially, they also observed an increase in the acromiohumeral distance after the surgery, suggesting that the partial repair actually helped to recenter the humeral head, even though they didn't achieve full anatomical coverage.
That's really encouraging, isn't it? That focusing on restoring those key biomechanical elements, even with what looks like an incomplete anatomical repair, can still lead to good functional outcomes and potentially even improve the joint mechanics.
Yes, it suggests that sometimes less is more if you target the right structures.
Now, let's move into what are often considered the more involved surgical options. Tendon transfer procedures. When do these typically come into play?
Tendon transfers are generally reserved for a quite specific subset of patients. Typically, we're thinking about younger, more active individuals who have a really significant functional deficit, things like severe weakness or a major loss of rotation, specifically because of an irreparable tear. They are usually considered when simpler procedures, like the debridement or even a partial repair, aren't really expected to address the primary problem, which is often that profound muscle weakness. The sources often refer to them as salvage procedures.
Salvage.
Yes, because they are complex undertakings used when the less invasive options are deemed insufficient and perhaps joint replacement isn't yet indicated, often because the patient is younger or they don't have significant arthritis in the joint yet.
So definitely not for everyone, but perhaps for those with severe disability who really want to regain significant function.
Exactly that. Careful patient selection is absolutely paramount here. The factors influencing the decision include the patient's age and their activity level, their overall health, and any other medical conditions, the specific pattern of weakness and functional loss they're experiencing, the stability of the joint itself, and critically, as I mentioned, the absence of significant glenohumeral osteoarthritis. If there's already advanced arthritis present, a tendon transfer is usually not a suitable option.
And the biomechanical idea here is essentially to use a different healthy muscle to do the job that the damaged rotator cuff muscle used to do.
That's the core principle, yes. You're essentially rerouting a working muscle and its tendon from somewhere else around the shoulder or even the trunk and attaching it to the bone near where the torn rotator cuff tendon used to insert.
Mm-hmm.
The goal is to restore that lost force couple, improve the kinematics, the actual movement patterns of the shoulder, and thereby hopefully restore strength and function. The specific muscle chosen depends very much on which part of the rotator cuff is irreparable. Is it the posterosuperior section or the anterosuperior section?
Okay, let's break that down by the tear location then. For those irreparable posterosuperior tears, the ones involving the supraspinatus and infraspinatus at the top and back, what are the main transfer options?
Well, the most established and perhaps best known transfer for posterosuperior tears is the latissimus dorsi transfer, often abbreviated as LD transfer.
Yeah.
The latissimus dorsi is that large muscle in the back, sometimes called the lats, that primarily functions as an internal rotator, an extensor, and an adductor of the arm.
Right.
By carefully detaching its tendon from where it inserts on the humerus and rerouting it up and over to the area of the torn supraspinatus and infraspinatus, it can actually be retrained to help with external rotation. And importantly, it can also provide a downward pull on the humeral head, which helps to counteract the upward pull of the deltoid muscle that happens when the cuff is deficient.
So you're effectively teaching a muscle to do pretty much the opposite of its original job.
That's a simplified way to put it, yes. With dedicated postoperative rehabilitation, the patient learns to activate the transferred muscle to assist with movements like external rotation, and sometimes it can help with abduction too, lifting the arm out to the side. This procedure actually has quite a long history. It was originally used for nerve injuries like brachial plexus palsy.
Right.
Suitable candidates for an LD transfer typically have an irreparable posterosuperior tear with significant muscle atrophy and fatty infiltration, usually Gatalia grade 3 or worse. They have marked impairment of abduction and particularly external rotation, often demonstrated by positive lag signs on clinical examination.
And who would be excluded? Who isn't suitable for this?
Key contraindications highlighted in the literature include significant subscapularis tendon insufficiency, that's the muscle at the front. If that muscle is also not working well, the overall stability and the ability to lift the arm forward will likely be compromised, even with the transfer.
Okay.
Also, advanced eccentric arthritis hamata stage 4 or higher established pseudoparalysis that isn't simply due to pain inhibiting movement, significant deltoid muscle dysfunction, and also severe fatty infiltration of the teres minor muscle, which is another important external rotator at the back. These are generally considered contraindications. The sources really stress the need for an intact and well-functioning subscapularis for the LD transfer to have the best chance of success, particularly for restoring forward elevation.
How is this transfer actually performed surgically?
Historically, it often involved a two-incision technique, one incision on the back to harvest the LD tendon and another on the shoulder for the insertion. More commonly now, surgeons use single-incision approaches or even arthroscopy-assisted techniques to try and minimize the surgical invasiveness. Habermeyer described a single V-shaped incision that can apparently improve visualization.
And what about the outcomes for LD transfer? Is it reliable? Does it work well?
It is generally considered very effective for reducing pain and improving function, although restoring full normal strength is perhaps more variable. Long-term follow-up studies, such as those published by Gerber's group, have shown significant improvements in subjective shoulder value scores, constant scores, pain levels, and also active range of motion, including gains in that crucial external rotation.
But
However, they also found that factors like pre-existing subscapularis insufficiency or severe fatty infiltration of the teres minor were indeed associated with poorer outcomes, which really reinforces the importance of that careful patient selection we discussed.
what about the Lepiscopo procedure? Is that something different?
The Episcopo procedure is related, yes. It's essentially a modified technique that adds the transfer of the teres major muscle, along with the latissimus dorsi.
Okay.
This was also initially used for brachial plexus injuries, but it's been adapted for massive rotator cuff tears, particularly for addressing really severe external rotation deficits. The idea of including the teres major is to provide some additional external rotation power. Boileau and colleagues have even described combining the Lepiscopo transfer with a reverse shoulder arthroplasty in certain very complex cases.
So adding even more complexity to specifically target that external rotation deficit.
Precisely. Another transfer that's been gaining quite a bit of attention more recently for posterior-superior tears is the lower trapezius transfer, or LT transfer.
The lower trapezius, that sounds like a completely different approach. How does that work biomechanically?
Well, the lower trapezius transfer involves harvesting the distal lower portion of the LT muscle and its tendon. This is typically augmented with a graft, often an Achilles tendon allograft, sometimes with a piece of bone block attached. And this graft is then rerouted around the side of the scapula, the shoulder blade, to be attached to the footprint of the torn infraspinatus, or perhaps the posterior supraspinatus on the humerus.
Does taking part of the trapezius muscle affect scapular movement or stability? That sounds like it could be a concern.
That's a very valid concern, yes, and the sources do discuss it. However, the general consensus seems to be that if the serratus anterior muscle, which is another key scapular stabilizer, is functioning normally, the risk of developing significant scapular winging or instability from harvesting just the lower portion of the trapezius is considered relatively low.
What kind of results are reported for the LT transfer then?
Studies, like one by Alhassan and colleagues, have reported really quite significant improvements in active range of motion after lower trapezius transfer for these irreparable posterior-superior tears. Specifically, they noted gains in abduction, forward flexion, and external rotation, as well as substantial reductions in pain levels.
And how does it stack up biomechanically against the more traditional LD transfer? Is one better?
This is where the comparison gets really interesting, actually. Biomechanical studies, including work by people like Hartzler and Omid, have compared the moment arms of these different transfers. The moment arm essentially tells you how effectively the muscle's force can generate rotational movement at the shoulder joint.
Right.
Their findings suggest that the lower trapezius transfer might actually have a larger external rotation moment arm, particularly when the arm is in an adducted position close to the body. Omid's study specifically proposed that the LT transfer might be biomechanically superior to the LD transfer in terms of restoring the native glenohumeral mechanics and the joint forces required for both elevation and rotation.
So potentially a more powerful or perhaps more efficient muscle substitute for restoring those lost movements, depending on the arm position.
That's certainly the implication from the biomechanical analysis, that it could provide a more, shall we say, natural force vector for shoulder function compared to the LD.
That covers the posterior-superior side pretty thoroughly. What about irreparable tears on the other side, the anterosuperior side, primarily involving the subscapularis tendon, the SSC?
Yes, anterosuperior tears, particularly isolated irreparable subscapularis tears, are generally less frequent than posterior superior ones, but they cause quite different functional deficits. Patients typically present with pain at the front of the shoulder, anterior shoulder pain, and significant weakness in internal rotation. This makes tasks like tucking in a shirt or reaching behind the back very difficult. Clinically, tests like the belly press test, the bear hug test, and the lift-off test are usually positive, indicating that internal rotation weakness.
And similar to the posterior tears, I assume direct repair is often unsuccessful if the tissue quality is poor.
Exactly the same principle applies, yes. For chronic SSC tears, especially those with significant fatty infiltration again, Goutallier grade 3 or higher direct repair has generally poor outcomes due to high rates of retear. So in these specific cases, tendon transfers are again considered as potential salvage options. And the primary transfer used for irreparable SSC cares is the pectoralis major transfer, or PMA transfer.
Transferring the pectoralis muscle from the chest, how does that help restore internal rotation?
Well, the pectoralis major is that large chest muscle that assists with flexion, adduction, and crucially, internal rotation of the arm. The procedure involves detaching its tendon from its insertion on the humerus and then transferring it more posteriorly and superiorly onto the lesser tuberosity, which is where the torn subscapularis footprint is located. This allows it to be used to provide active internal rotation power.
Who is the ideal candidate for a PMA transfer then?
Candidates typically have an irreparable anterosuperior tear involving the subscapularis. They should have minimal to no significant glenohumeral arthritis. They need a well-functioning deltoid muscle. Generally, they're younger than about 65. And importantly, they need to have an intact or at least repairable posterior-superior rotator cuff, the supraspinatus and infraspinatus.
Why is the posterior cuff being intact so important for this anterior transfer?
Well, just as the subscapularis is crucial for the success of posterior-superior transfers like the LD, having a functioning posterior-superior cuff is absolutely vital for the overall balance and stability of the shoulder when the subscapularis at the front is deficient and being replaced by the pectoralis major transfer. The force couples around the joint need to be balanced for effective movement and also to prevent that superior migration of the humeral head.
Right, makes sense.
In terms of surgical technique, there are different approaches described for the PMA transfer. Some transfer the tendon anterior to the conjoined tendon that's formed by the short head of the biceps and the coracobrachialis, while others prefer to pass it underneath the conjoined tendon. Dr. Warner described an approach specifically underneath the clavicular head of the pectoralis major, which aims to avoid potential injury to the musculocutaneous nerve, which can be a risk during this procedure. Whilst large comparative studies looking at these different techniques are perhaps scarce, authors like Resch and Galatz have reported generally satisfactory clinical outcomes following PMA transfer. They show significant improvements in pain and functional scores, including increases in AC scores, demonstrating restored internal rotation strength and improved overall shoulder function.
So it seems like an effective option for restoring that lost internal rotation, provided the patient selection is right. Are there any other transfer options for these anterosuperior tears?
Yes, the pectoralis minor transfer, PMI, has also been used. This is sometimes used in conjunction with a graft, or perhaps as a smaller transfer option, depending on the tear pattern. Wirth and Rockwood were among the first to describe using the PMI tendon, either as a graft or as a direct transfer, for irreparable subscapularis tears.
And when might that specific transfer be indicated?
It's typically considered for tears that involve mainly the upper two-thirds of the subscapularis tendon, rather than the entire tendon. Palladini and colleagues described a specific technique involving transferring the pectoralis minor, along with a small piece of the coracoid bone where it attaches, onto the superior two-thirds of the subscapularis footprint. They often use this for combined irreparable tears involving both superior cuff, supraspinatus, and the upper subscapularis. Their study reported good outcomes at a 2-year follow-up, with significant improvements in constant scores, and also a high rate of patients being able to return to their previous daily and even recreational activities. So it suggests this can be a viable option for certain specific patterns of complex anterosuperior tears.
It's really remarkable, isn't it, how many different muscles surgeons can potentially repurpose to try and restore lost function around the shoulder. Beyond these muscle transfers, the sources also discuss using different types of grafts, biological or synthetic materials, to either augment repairs or bridge large defects.
Absolutely. Graft augmentation techniques represent another important strategy in the armamentarium for massive or irreparable tears. This is particularly relevant where there's a large gap in the tendon tissue that simply cannot be closed, even partially, without creating excessive tension.
Right.
The idea here is to use biological materials, or sometimes synthetic ones, to provide structural support, essentially bridge the defect, or potentially even enhance the biological healing environment.
What kind of materials are typically used for these grafts?
Well, they can be interpositional grafts, meaning they're placed between the torn edges to bridge the gap, and they can come from various sources. Allografts, which are derived from human donors, include materials like human dermal allograft skin or fascia lata allograft, a tough connective tissue from the thigh. Autografts are harvested from the patient themselves, most commonly fascia lata from their own thigh, or perhaps a strip of iliotibial band, also from the leg.
Okay.
Synthetic grafts and also extracellular matrix products exist too, although the provided literature seems to focus more heavily on the biological grafts for this purpose, for interposition. A review by Sunwoo and Merle looks specifically at the biomechanical properties of these different graft types. They found that biological grafts like the allografts and autografts from fascia lata or iliotibial band tend to have quite similar stiffness and maximal load to failure compared to the native rotator cuff tendons themselves. Synthetic grafts, they found, might have similar load capacity but were often less stiff. And extracellular matrix grafts were typically lower in both stiffness and load capacity. This biomechanical understanding is quite important, isn't it, for predicting how well a particular graft might function under the stresses experienced in the shoulder.
Absolutely. And clinically, do these grafts actually improve outcomes for patients?
Well, the clinical evidence presented in the sources is generally quite positive, suggesting that grafts can indeed be a valuable adjunct in selected cases.
Yeah.
Dimitrios et al., for instance, reported improvements in pain and constant scores using a fascia lata allograft for interposition, and they noted relatively low re-tear rates in their series.
Okay.
Pandey et al. Conducted a study where they found that using a dermal allograft to augment a partial repair actually improved outcomes measured by the Oxford Shoulder Score and Constant Score compared to just doing the partial repair alone for symptomatic irreparable tears.
So adding the graft actually improved the results compared to just doing the partial repair on its own.
That was their specific finding, yes. It suggests the graft provided some beneficial structural support or perhaps enhanced the healing process. Mori et al.'s study using fascia lata autograft highlighted an interesting point. Its efficacy seemed to be linked to the degree of fatty degeneration already present in the remaining muscle. The grafts appeared to perform better when the fatty infiltration was less severe.
That makes sense.
Which makes sense biologically, doesn't it? The muscle has to be functional enough to actually load the graft effectively for it to work. And Mahara et al. Described using an iliotibial band autograft which had a bone block still attached. This bone block was then fixed directly to the humerus bone. They reported good pain relief, functional scores, and range of motion improvements. They also noted that the bone block successfully united to the humerus, and importantly, they reported no significant donor site morbidity from harvesting the graft.
It sounds like these biological grafts show quite a bit of promise then, particularly according to that Sunwoo and Merle review, which, as you mentioned, noted promising 2-year outcomes regardless of the specific biological graft type used, and with relatively few complications reported.
Yes, that review certainly provided a positive outlook on the potential role of biological grafts, either for augmentation or interposition, in selected cases of irreparable tears, at least in the medium term.
Building on that concept of using grafts, another technique that's received significant attention in recent years is superior capsular reconstruction, or SCR. This seems specifically designed to address a fundamental biomechanical problem caused by these large tears.
It is, yes. The rationale for SCR, which was really pioneered and popularized by Dr. Teruhisa Mihata in Japan, is based on the concept that these massive irreparable tears often result in a deficiency not just of the rotator cuff tendons themselves, but also of the superior capsule of the shoulder joint.
Huh.
This superior capsular defect is thought to contribute significantly to the glenohumeral instability and that upward migration of the humeral head that we keep talking about. It's part of what Mihata termed the circle concept of instability that occurs in the setting of rotator cuff deficiency.
So the tear isn't just a hole in the tendons, it actually compromises a key stabilizing structure right on top of the joint itself.
Exactly that. The goal of SCR is therefore to reconstruct that deficient superior capsule in order to restore passive stability to the joint and prevent that superior translation or upward movement of the humeral head. The original Mihata technique involved using a folded graft, typically fascia lata, either harvested as an autograft from the patient's thigh or using an allograft. This graft is then meticulously fixed medially to the superior aspect of the glenoid rim, the edge of the socket, and laterally to the greater tuberosity footprint on the humerus where the supraspinatus would normally attach. It essentially creates a new superior constraint, like putting a roof back on. It's also often sutured to any remaining viable rotator cuff tissue at the front or back.
And what's the specific biomechanical goal of this complex reconstruction?
Well, by restoring that superior constraint, the procedure aims to recreate the normal force couple mechanics around the shoulder. It aims to significantly increase the acromion-humeral distance by effectively pushing the humeral head back down into a more centered position. And thereby, it aims to improve the instability caused by the underlying cuff deficiency.
And were the reported outcomes impressive? It sounds like a big procedure.
They were indeed, yes, and they generated considerable excitement within the orthopedic community. Mihata's original studies, primarily using the fascia lata autograft, showed really quite dramatic improvements in clinical scores, things like the AC score, the JOA, Japanese Orthopedic Association score, and the UCLA score. They also showed significant gains in active range of motion and, importantly, objective evidence on postoperative imaging of corrected instability and that increased acromiohumeral distance.
That sounds like a potential major breakthrough for certain types of patients then. Who is the ideal candidate for an SCR procedure?
It's typically indicated for younger, more active patients who have massive, irreparable posterior superior rotator cuff tears, but who do not have significant pre-existing glenohumeral osteoarthritis.
No arthritis.
Correct. They often have specific patterns of fatty degeneration and tendon retraction, but crucially, their humeral head should not be rigidly fixed in a high-riding position. It needs to be reducible.
How do you actually know if it's fixed high riding?
Well, a key clinical test often performed is the sulcus maneuver. If the surgeon can apply gentle downward traction on the patient's arm, and the humeral head visibly translates inferiorly, creating a sulcus or dimple just below the acromion bone, it suggests that the head is still mobile and reducible, not fixed rigidly in its superiorly migrated position.
Okay.
This indicates there's enough mobility left in the joint and the surrounding soft tissues for the SCR graft to potentially be effective in stabilizing the head in a better position. If the head is already fixed high and cannot be reduced, then SCR is generally contraindicated.
And are there variations or evolutions of the technique being used now?
Yes, definitely. Other graft sources are being explored. For instance, using the long head of the biceps tendon as an autograft after performing a tenotomy has been described by Chillemi and others. This potentially eliminates the need for a separate donor site harvest from the leg. Different techniques for graft introduction and fixation are also continually being refined to try and improve the procedure and outcomes.
This leads us naturally, I think, to perhaps the most definitive surgical option for many of these complex, irreparable tears, reverse total shoulder arthroplasty, or RTSA.
Yes, RTSA has truly transformed the management of these complex shoulder problems over the past couple of decades. It's now often considered a primary first-line treatment for very specific indications related to irreparable rotator cuff deficiency.
What are those key indications where RTSA is considered upfront?
Well, the most prominent indication is probably patients who have a true pseudoparalytic shoulder resulting from an irreparable tear. That means they simply cannot actively elevate their arm effectively because the rotator cuff is completely non-functional as a prime mover. Another major indication is the combination of an irreparable rotator cuff tear with significant pre-existing glenohumeral osteoarthritis. This specific condition is often termed cuff tear arthropathy.
Okay.
RTSA is also often considered for patients who are perhaps not ideal candidates for arthroscopic procedures or tendon transfers, maybe due to their age, their general health, or the specific nature of their tear and resulting dysfunction.
And remind us why it's called reverse arthroplasty.
Yes, well, unlike a conventional or anatomical total shoulder replacement, where a metal ball is placed on the humerus side and a plastic socket is put on the glenoid side, mimicking normal anatomy, in a reverse replacement, the geometry is flipped or reversed.
Okay.
A metal hemisphere called the glenosphere is fixed onto the glenoid bone, the socket side, and a plastic socket or cup within the humeral component is placed on the top of the humerus, the arm bone side. This design effectively lateralizes and distalizes the center of rotation of the shoulder joint.
And how does that change in geometry help patients who have a non-functioning rotator cuff?
By changing that center of rotation, the deltoid muscle, which is usually intact and strong in these patients, becomes a much more effective lever arm for elevating the arm. It essentially bypasses the need for a functional rotator cuff to lift the arm overhead, allowing the powerful deltoid muscle to take over this crucial role.
That's quite an ingenious biomechanical solution, isn't it? And what about the outcomes for RTSA? How well does it work?
Systematic reviews, like the one by Petrillo et al. That you provided, consistently show statistically significant improvements in clinical scores and also in active range of motion, particularly in forward elevation and abduction. Patients who were previously pseudoparalytics often regain quite functional elevation of their arm. However, these reviews also often note limitations, particularly in reliably restoring active external rotation, which can sometimes remain weak even after a successful RTSA. And the Wall et al. Review specifically highlighted that the best functional results from RTSA are typically seen in those patients with established cuff tear arthropathy. That's where the combination of pain relief from the arthritis and the restored elevation function leads to the most dramatic improvements, often showing very significant increases in constant scores.
So it's particularly effective at restoring the ability to lift the arm, especially when there's significant arthritis involved as well. What's the main downside then, or the major concern with RTSA?
The primary concern, which is consistently highlighted in the literature, is the risk of significant perioperative complications compared to some of the less invasive procedures we've discussed. That Petrillo review, for instance, compiled complication rates from multiple studies. They reported figures like 2.4% from mechanical failure of the implants themselves, 2.7% for fractures of the acromion or scapular spine occurring after the surgery, almost 1% for deep infections requiring further treatment, and around 6.6% for heterotopic ossification, that's abnormal bone formation around the new joint.
Those numbers do sound quite significant.
They are, yes. And whilst revision surgery might eventually be needed for any shoulder procedure, the risk with RTSA is generally considered higher, and revision RTSA surgery can be particularly complex and challenging. These potential complications require very careful patient counseling and consideration, especially perhaps in younger or healthier patients where other, less definitive options might still be preferred initially if possible. It's also worth noting, going back to that issue of external rotation, that for patients where restoring external rotation remains a major functional goal, some surgeons have explored combining the RTSA procedure with a latissimus dorsi, or perhaps an Lepiscopo transfer at the same time. Authors like Boileau and Bouibri have reported on this, attempting to address that specific rotational deficit concurrently with the joint replacement.
Okay, wow. We have covered an absolutely vast spectrum of options here, haven't we? Ranging from potentially encouraging results with just physiotherapy right through to complex muscle transfers and joint replacement. Given this huge range, how does a surgeon actually navigate this and decide which procedure is the right one for a given patient presenting with an irreparable tear?
Yes, this is absolutely the crux of the challenge, isn't it? And it brings us right back to the idea of a decision pathway, which is hinted at in the sources. The reality is there's no single simple algorithm that applies perfectly to every single patient. It requires really careful consideration of multiple factors, starting fundamentally with the patient themselves and what their goals are.
Let's try and walk through that decision process logically then.
Okay, well, it really begins with a thorough patient assessment. We need to know their age, their activity level, their functional demands. What do they need and want to do with their shoulder? Their overall health and any comorbidities are crucial. And critically, what is their primary complaint? Is it mainly pain? Is it weakness? Or is it that inability to lift the arm, the pseudoparalysis?
Mm-hmm.
Then on clinical examination and looking at the imaging, x-rays, MRI, the surgeon assesses the specific tear pattern, which tendons are involved, how retracted are they, what's the quality of the muscle litter, like how much atrophy and fatty infiltration is there, what's the acromiohumeral distance, is the joint stable, and importantly, is there any osteoarthritis present? And if so, how severe is it?
So gathering all those different pieces of information together first is key.
Exactly. Then the initial approach, as we discussed right at the beginning, is often conservative management, especially for those patients who don't have significant superior migration of the humeral head yet. Physiotherapy focused on strengthening the remaining muscles, particularly that anterior deltoid, is really key here.
Right.
If pseudoparalysis is present, sometimes a diagnostic injection of local anesthetic into the joint can be helpful. It can help differentiate if the inability to lift the arm is purely due to pain inhibition, in which case blocking the pain might temporarily restore some movement, or if it's due to an absolute mechanical deficiency of the cuff.
And if that conservative care fails to provide adequate relief, particularly for ongoing pain.
Then the arthroscopic options come into consideration. Arthroscopic debridement and bursectomy are often the primary choices specifically for pain relief, especially perhaps in older or lower demand patients where function might be less of a concern than comfort. Adjuncts like a biceps tenotomy might be added if there's clear evidence of biceps pathology contributing to the pain. A partial rotator cuff repair could be attempted if it seems that a functional repair, restoring those key force couples, might be achievable based on the remaining tissue quality and its mobility. And suprascapular nerve release would only be considered if there's specific evidence pointing towards nerve involvement causing pain or weakness.
Where does the subacromial spacer fit into this decision pathway now, given the recent evidence?
Oh, that's a good question. And its place is perhaps less clear-cut now than it might have seemed a few years ago. Based on some of the initial reports, the spacer was often positioned in the pathway as an option for patients who had failed conservative care, but perhaps weren't deemed suitable candidates for a partial repair or more complex transfers. The idea was it could restore some subacromial height and facilitate therapy. But, as we've highlighted, the more recent conflicting evidence, particularly regarding its questionable impact on radiographic progression and perhaps lower functional outcomes, coupled with that non-negligible complication risk, makes its precise role in the decision pathway much more debated now and probably quite surgeon-dependent. It's fair to say it's a procedure where the clinical indication is currently undergoing significant reevaluation based on this evolving data.
That's a really important point of nuance to understand. What about the more involved transfers then? When do they come in?
The tendon transfers are typically reserved for those younger, more active patients who have specific, significant functional deficits resulting from chronic irreparable tears, but crucially, who have minimal or no arthritis. The choice of which transfer to perform is dictated primarily by the location of the irreparable tear and the resulting functional loss. So, latissimus dorsi, or perhaps the episcopal modification, for posterosuperior tears, where there's significant external rotation weakness, provided that the subscapularis at the front is intact and functional. Pectoralis major, or maybe minor, transfer for anterosuperior tears causing internal rotation weakness, provided the posterior cuff is intact. But remember, these are generally considered salvage procedures for severe functional loss, not routine operations.
And the graft augmentation or the SCR procedure, where do they fit?
Grafts used for augmentation or interposition are options when there's a large tissue defect, potentially to improve the outcomes of a partial repair or to bridge a gap that simply can't be closed otherwise. Superior capsular reconstruction, SCR, is a much more specific reconstructive technique. It's typically considered for younger, non-arthritic patients who have massive posterosuperior tears where the humeral head is reducible but demonstrably unstable superiorly. It's a complex procedure aimed squarely at restoring that superior stability.
And finally, the RTSA, the reverse replacement.
Reverse total shoulder arthroplasty is often the go-to or perhaps the default option for patients who have that combination of significant osteoarthritis and an irreparable tear-of-the-cuff tear arthropathy patients. Or for older patients who present with a true pseudoparalytic shoulder and aren't really suitable candidates for transfers or other reconstructive procedures. It's also used when other surgical options have failed. Its main strength, as we said, is reliably restoring elevation, particularly in the presence of arthritis, but that higher potential complication rate always has to be factored into the decision-making and patient selection process. So you can see the surgeon is essentially weighing up the patient's age, their functional goals, their overall health, the specific anatomy and muscle quality relating to the tear, the presence and severity of any arthritis, and then the relative risks and benefits of each potential procedure. They're moving along this continuum from simple interventions towards more complex ones, really aiming to match the right solution to that individual patient's specific problem.
It's truly a complex puzzle, isn't it? It requires such a deep understanding of both the pathology itself and all the available tools in the surgical toolbox, as you've so clearly laid out for us.
Absolutely. And the literature really reflects this complexity. The ongoing research, as we saw very clearly with the differing findings on the subacromial spacer, continues to refine our understanding of which procedure works best for which patient and under exactly what circumstances. The challenge, really, of selecting the correct indication for each procedure remains absolutely paramount in this field.
Well, what a comprehensive deep dive into a really challenging area of orthopedics. So just wrapping this all up and perhaps thinking about the future, given the variable outcomes we've heard about for some procedures and that crucial need for meticulous patient selection and surgical technique, how might future innovations potentially move beyond the current strategies of compensation and reconstruction? Could we perhaps look towards more predictable long-term solutions or even biological regeneration for patients who are facing these complex irreparable tears?
That's the really compelling question, isn't it? That's what drives the continued research in this field. Will we see perhaps more effective biological scaffolds that truly integrate with the host tissue and actively promote healing? Will advances in things like gene therapy or the use of specific growth factors help us to improve muscle quality before or after surgery? Or will entirely new biomechanical solutions emerge that we haven't even thought of yet? It's certainly an exciting frontier to watch.
A fascinating thought to leave us with. Thank you so much for guiding us through this really intricate topic today.
It's been my pleasure.
And if you, listening, found this deep dive valuable, please do take just a moment to rate and perhaps share the show with someone else who might benefit from a clear, evidence-based look at complex topics like this one. It really helps us to bring more insights like these to you.